contest, which is for the young surgeons who are wanting to uh, break through in this world of academics. And so US is trying to provide a podium for uh, and encouraging these young surgeons. And by now, you all know the guidelines that it is a 7-minute presentation with question answer. The whole emphasis on uh, uh, literature review and your point of view on such literature related relevant to your topic. So today, this is the spine session. I welcome you all. I also welcome the judge, Dr. Ashok Rathod, who is a senior spine surgeon from Sion Hospital, a well-established spine surgeon, and Dr. Agnivesh Tikku, who is again a spine surgeon working in Apollo Hospital, Navi Mumbai, and Dr. Raj is there.
Yeah, he's there.
Yeah, Raj Satvekar, who is a young spine surgeon now back in Mumbai. So I welcome you all. I hand it over back to the Ashok to run you through this contest for the rest of the session. Thank you very
I'd like
much.
to invite Dr. Neeraj to state the rules and also about the judges. Go ahead, Neeraj.
So I thank all the three judges, Dr. Ashok Rathod, who's professor and head of unit of Sion Hospital, and he's not only a spine surgeon but a very good pelvic surgeon also. He has got so many students under his in so many years that I can say that he must have at least trained more than 100 spine surgeons under him. Then the next is Dr. Agnivesh Tikku. He's a consultant spine surgeon from Apollo Hospital, Belapur. Have the co-founder of Spine TV with us, Dr. Raj Sakrekar, who is basically an expert in making spine Instagram reels, and I'm hoping that he'll make some reels out of these today's lectures. So the person who performs the best, Raj, will basically take his interview and make his reel. So with this, I hand over to Ashok. But before that, let me tell you that presentation will be 7 minutes and 3 minutes will be Q&A. Mark sheet has been given to judges. So I hand over to Ashok now to start the session.
Thank you very much, Neeraj. Uh, Dr. Abhijeet is kind of stuck up in a surgery and he'll join us shortly. I'll invite the next candidate, Dr. Bhushan Hadole, to share his presentation and start. Dr. Bhushan, you can share.
Yes, sir.
Okay, we can see your presentation.
Okay. Thank you, sir. A very good evening to all the esteemed faculties and my colleagues. I thank you. I thank Bombay Orthopaedic Society for giving me this opportunity. My name is Dr. Bhushan Hadole. I'll be speaking on outcomes of endoscopic T-leaf versus MIS T-leaf. So transforaminal lumbar interbody fusion, the T-leaf surgery, it forms the basis of spinal fusion surgery. It was developed as an alternative to the posterior lumbar interbody fusion technique in the 1980s. It involves the midline incision with a dissection of the muscles around the paraspinal muscle for the spine exposure. It gives excellent exposure, but at the cost of significant blood loss, a lot of postoperative pain, and a delayed recovery time. To overcome the limitations of this open T-leaf surgery, we moved on to further advancement, that is the tubular MIS T-leaf surgery. This MIS surgery involves smaller incision, that is around 2 to 3 centimeter, with specialized tubes, which reduces the tissue damage, the blood loss, and the recovery time. But with it, it has a significant radiation exposure and a steep learning curve. With further advancement in technology, we moved into endoscopic T-leaf, which utilizes further small incision, that is around 1 to 2 centimeter. It utilizes endoscope and specialized instrument to dissect around the spine, but it requires a lot of training and expertise, but it gives unprecedented visualization and precision. So for my study, I referred to electronic database like PubMed and Google Scholar. I reviewed systematic reviews, meta-analysis, and randomized controlled trials. The outcome was studied on two bases: short-term, less than 3 months, and long-term, that is more than 12 months. I came across 3 meta-analyses which directly compared the outcome of endoscopic T-leaf versus minimally invasive T-leaf. The first study was conducted in 2024 by Haber et al. It had 13 literatures. around 1,015 patients of lumbar degenerative disease, with 493 patients treated with endoscopic TLIF and 522 patients treated with MIS TLIF. The second group, which was studied in 2022 by Hawaii Geo, had 8 articles with 581 patients, of which 286 were treated with endoscopic TLIF and 295 patients were treated with MIS TLIF. The third article, it has 224. The third meta-analysis had in 2024. It was done by Shawin Geo, had 8 studies with a total of 687 patients, of which 335 patients were treated with endoscopic TLIF and 352 patients with MIS TLIF. The outcomes were studied under the following headings. The first is VAS score for low back pain. Well, with all the 3 meta-analyses, I studied that the VAS score for endoscopic TLIF group in the short-term follow-up was significantly lower compared to the MIS TLIF group with a p-value of 0.002. However, there was no significant difference between the 2 techniques at long-term follow-up. The second was score of the leg pain, which had no significant difference in both the groups at short-term as well as long-term. The ODI score was also studied in all the 3 meta-analyses. It showed that the improvement in patients' functional status in the endo-TLIF group was significantly better than those in the MIS TLIF group at short-term follow-up with a p-value of 0.008. However, there was no significant difference at long-term follow-up. The operative time in the endo-TLIF group was significantly longer than those in the MIS TLIF group, with the blood loss being more in the MIS TLIF group than the endoscopic TLIF group. The length of hospital stay. The endo-TLIF group had significantly shorter length of hospital stay than the MIS TLIF group, which is a p-value of 0.002. Incidence of complication. The rate of complication was around 4.4% in the MIS TLIF group and 4.9% in the endoscopic TLIF group, with no statistically significant difference. Fusion rate. At 12 months follow-up, both the groups showed equal fusion rate with no statistical difference. Radiation exposure. There was no direct study which showed a comparison between the radiation exposure in endoscopic group and minimally invasive group. However, these 2 studied, as I could infer that the radiation dose in the endoscopic surgery group was around 59.08 plus minus 9.77 milligray, while in the MIS group it was around 76 mrem, which is lesser as compared to the endoscopic group, suggesting that the radiation exposure is significantly higher in the endoscopic TLIF group. On conclusion, the endoscopic TLIF as well as MIS TLIF have similar clinical outcomes, including pain relief and functional outcome in long terms. Endoscopic TLIF has advantage in terms of less blood loss, shorter hospital stay, and faster recovery, while MIS TLIF has shorter operative time, lesser radiation exposure as compared to the endoscopic TLIF group. My take-home message is a careful patient selection is crucial to optimize outcome and minimize the complication. Larger and prospective studies are needed to confirm the findings of this review, and long-term outcomes and cost-effectiveness of the endoscopic TLIF and MIS TLIF should be evaluated. These are my references. Thank you.
Thank you. I'd like to invite the judges for questions. Ashok sir, you can start.
So what's your conclusion? You did not specify any particular indications regarding MIS or an endoscopic. I think all the studies have got enough a number of patients, almost 350 to 400 to almost an equal size. So
Yes.
probably from the articles, could they make out, like I said, probably these are the specific, because I think your concluding remark was that, like we should have a proper selection of patients for each
Yes.
of them. So you did not specify which are the absolute indications or which are the relative indications for MIS or endoscopic.
Sir, the studies that I've reviewed, even those studies could not give specific indications for MIS and endoscopic theory, but I would suggest those requiring those complex surgeries should be considered for MIS TLIF rather than endoscopic approaches.
I think you're speaking the contrary, since a majority of the complex surgeries you need a good visualization. And as you said, endoscopy provides probably a better visualization than MIS.
Yes, sir.
And you are quoting it now, possibly complex surgery should be submitted more for MIS than endoscopic.
which requires
So
more bony dissection.
a bony dissection will be equal, like I suppose, because then if you're going to do a bony or a trans foraminal interbody
Yep.
fusion, obviously you are going to be instrumenting it. You are
Yes.
going to be uh, a disc preparation,
Yes.
and then obviously you are going to be doing a cage insertion and the bone grafting. So the amount of radiation, that is another thing. The amount of radiation also should be equal, because except for the visualization, majority of the things are almost very similar in MIS as well as endoscopic. So, what, according to you, what should be the ideal candidates for either of them? I mean, after the review of literature and everything, yeah. Can you throw some lights on that?
Uh, no, as for the literature that I reviewed, would not give a direct consensus about the ideal candidate that should be put into endoscopic or MIS group.
Okay. Agnivesh, you want to throw some light from the current generation of spine surgeons?
No, sir, I have a question for Dr. Bhushan in case I missed it. That did he mention how he did the literature review? How he chose the articles, how many were excluded, for what reasons and all? Dr. Bhushan, did you
So,
mention that in your slides?
so I did not put any exclusion, but yes, I put a exclusion criteria like not more than 10 years old articles. Then those comparing the functional outcomes. I chose only articles those shows the functional outcome, and I preferred doing it in two bases, like those were having a short-term outcome as well as a long-term. So long-term, the only thing you could suggest was fusion. For short-term, I used the keyword like short-term outcome and long-term outcome, and then I put up the criteria like not more than 10 years old to do my literature review.
Okay. Because if you see, most of the MIS TLIF articles would be at least 15 years old
Yes.
when the procedure actually started, and endotelif has just come in the last decade or so. One more question. In your conclusion, you have said that more studies are needed to prospective, and these studies are needed to confirm the finding of this review. But yours is a review itself. You have already done the review of the available literature. So what makes you say that that you have to have more studies to prove the
Uh,
findings of this?
uh, so the studies that I reviewed had a follow-up of around only 12 months. So more studies with long-term follow-ups are needed. Long-term follow-up is needed to confirm this findings that the outcomes are similar even in further long-term of the patient's this what is the life. These are
But
just
would
for
your long-term follow-up outcomes or the parameters where you would check the long-term outcomes change as compared to a short-term outcome?
Uh, no, sir, but then development of other further complications like adjacent segment disease or that has to be also studies, which was not mentioned in any of these studies.
Okay, thank you.
Thank you.
Any questions, Raj?
No questions from my end. Thank you.
Ashish, Dhar sir, any questions?
Can I ask a question? I'll ask a few questions. Bhushan, I'm not a spine surgeon, but it is quite an interesting study, well presented, and you presented those three papers very nicely. But as a surgeon who would like to refer my patients to a spine surgeon, I just need some more information, right? So you said that there was a difference in the number of days stay
Yes,
between
sir.
it was favoring the endoscopy. How many days difference did it make actually?
So the endoscopy had a stay of around 2 days on an average in the literature, while the my MIS group had around 7 days. But that there was not a clustering. But on an average, the endoscopy patient had a stay of around 2 days, while the MIS group had around of 7 days stay.
And there are three more things. I mean, one is there a cost difference between these two
Yes.
procedures? Secondly, has anyone mentioned about the learning curve?
Yes.
And do you make more mistakes in the earlier part in which particular type of surgery? And have they compared the same cage instrumentation and screws to different set? I mean, is it the same company that manufactures endo-TLIF instrumentation as well as MIS TLIF? Or, I mean, this question I'm coming from a non-spine surgeon completely. But I'm just asking, are we comparing like for like?
So coming to the first question, that yes, they did compare one study where there was a surgeon who trained another three his fellows, and then the time they took to do the same surgery was higher as compared to the master himself. So there was one study which I went through, but I did not mention in my review of literature. The other thing, cost effectiveness, yes, sir, the cost of endoscopy is instruments is much higher. Uh, like we have to have the entire set of endoscope instruments, so that does incur in the cost. And the third question, sir, there was no study comparing like similar what do you say manufacturer for both endoscopic and MIS TLIF. Like there was no study regarding this.
But to your knowledge, does the same company manufacture the same set of, I mean, is it the same set of instruments that are used for both? I
Yes.
mean, I mean to say the implants, not the instrumentation, the implants.
Yes, sir, there are companies who manufacture both.
Okay.
Yes.
Okay.
That's it.
Thanks a lot, Dr. Bhushan.
Thank you, sir.
Dr. Naveen, you can share your presentation. We can start.
Yes, sir. Sir, can you see my slide?
It's still coming online. It will come. Yeah, we can see it now.
Yes, sir.
We can see the presenter view also. So go to display settings and yeah. You can't use the presenter view on Zoom because it shares the entire screen. Now go to the display settings upstairs and change the presenter view.
Yes.
Yeah, duplicate slideshow.
Now, sir.
No, not yet. Maybe you can stop sharing and then do it.
Not yet.
Not yet.
Are you presenting it from a iPad?
Laptop, sir. It's my lap. I'm not able to select the duplicate slideshow option.
Even when you're not sharing?
Okay. Sorry. This.
You have to go to the slideshow tab and uncheck the box use presenter view. Share again. Let's see. Okay, we can see it now. But there is a okay. Show
Now,
present.
sir.
Okay, go ahead. One slide.
Now, sir.
Yeah, we are able to see, but there is a, I think, zoom bar on the right side of the panel. Just take it out on the corner. Drag it from your screen where you can see our videos. Now, can you see our videos on the right side of your screen?
Yes, sir.
Yeah, just drag it out of the view. Are you able to do that?
No, sir. Mm.
So on the top of that panel on the right side, you can see, yeah, okay.
Stop sharing. And
Okay, maybe you can try and figure it out at your end and we can take the next candidate. Let me know in the text box once you're ready. Dr. Rishikesh, we can start with you.
मेरे को ये ऋषिकेश नहीं दिख रहा है.
Okay. Dr. Deepika, we can start with you now. Okay, this we can see. Go to the slideshow. Yeah, we
Yes.
can see now.
sir, now?
Yeah, Dr. Naveen, you can go ahead. I'll start your
Yes, sir.
timer.
Okay.
Go ahead, you can start.
Sir, 1 second, ma'am. That's
Just tap on the screen once, it will start moving. Yeah.
sir, I can start now.
Yeah, you can start.
Yes, sir. Sorry for that, sir. Good evening, respected judges and colleagues. Myself, Dr. Naveen. I'm doing FNB Spine Fellowship in Hinduja Hospital, Mumbai. Today, I'll be discussing this important question that we frequently face in clinical practice. Okay. This question is important because symptomatic ischemic listhesis affects the younger age group where early return to work is important because they have more active lifestyle. So we need a procedure which helps in faster recovery. Is there any evidence that says MIS would achieve that? Let's see what literature has to say. So I have broken down my topic into Pico format as you can see, and the key outcome I'll be analyzing are all related to return to function. Interestingly, no review the literature. There are no many papers that discussed only on return to function, but functional score like VAS score, ODI score, which can be given us indirect idea on recovery. There are very few direct study comparing MIS and open fusion specifically for ischemic listhesis. There are all mixed age population including degenerative and ischemic. Here, outcome for ischemic and degenerative considered together because this trial by Kim et al. In 2015, MIS TLIF shows functional improvement in ischemic cases is similar to degenerative ones, which are the bulk of MIS and open literature. So we can reasonably infer that MIS provides similar recovery advantages in ischemic and degenerative cases. This is a study in 2024 retrospective cohort study by Ali et al. Published in Journal of Orthopaedic Surgery and Research comparing 72 patients. The result shows the ODI score before surgery, after surgery, and at final follow-up at 1 year, all functional outcomes are statistically similar. But at 1 month, leg pain favoring the open group and the back pain favoring the MIS group. In a prospective clinical trial of Jain Bang et al. In 2010, published in European Spine Journal, compared 85 patients, which includes 39 ischemic cases and for 52 years age. This patient is MIS group had a less back pain VAS score than open group in the third day after surgery, but no significant difference in the final VAS or ODI score at last follow-up. Wang et al. In 2011 conducted a prospective randomized clinical trial published in Chinese Medical Journal providing level 1 evidence with 79 participants, mean age of 51 years and 2 years of follow-up. That shows VASCO showed no significant difference between MIS and open groups from pre-op till 2 years follow-up. But ODA score was better in MIS at 3 and 6 months, but no difference in the long run, which was at 2 years. This multi-center RCT by Brokema et al. In 2025, published in European Spine Journal, total of 169 patients randomized, included 104 patients with ischemic listhesis and 57 with degenerative type, with 1 year of follow-up. That shows no statistically or clinical significant difference between mini open and open groups for VAS back score and VAS leg pain score, ODI and ED 5D score at baseline at 1 year follow-up. This 2024 study by Liu et al. Published in Medical Research is a level 1 systematic review analysis and meta-analysis that concluded 44 comparative study comparing outcome of MIS and open fusion. That shows back pain, small but significant improvement favoring MIS at 6 month, 1 year and 2 year follow-up. MIS showed small but statistically significant better ODI changes at 1 month, 6 months, 1 year and 2 year. Parker et al. In 2012 conducted a systematic literature review focusing on return to work and narcotic use. Out of 137 studies screened, only 5 specifically reported on these outcomes. The only prospective comparative study reported both endpoints in detail was Adogwa et al. Return to work was 8.5 weeks in MIS and 17 weeks in open. Time to narcotic independence was 2 weeks in MIS versus 4 weeks in open. Ryu et al. In 2018 conducted a retrospective cohort study on ischemic listhesis, providing level 3 evidence of 45 patients total. The pain intensity for the back at post-op 1 month was greater in open than in MIS. The ODI score at post-operative month 1 and 6 were greater in open than in MIS, with significant difference between the groups. So perioperative parameters like MIS had significant less blood loss, transfusion, early postoperative back pain, and hospital stay. X-ray exposure and material complications were numerically higher in MIS, but open cases had shorter operative time and less radiation exposure. Minimally invasive fusion preserves paraspinal muscles and minimizes soft tissue trauma. This translates into less postoperative pain, quicker ambulation, and early discharge. Although fusion rates are similar to open surgery, patients tend to regain function faster. That's the key strength of MIS. And that's why it is relevant for young and active patients. So current evidence on MIS fusion is encouraging, but mostly derived from degenerative cases. Data specific to ischemic listhesis are limited, hence we need stronger prospective studies. With this literature review, I am making an interference that for young adults with low-grade ischemic listhesis will help in faster recovery because MIS fusion in degenerative and ischemic listhesis are equivalent, and overall there are several studies shows that MIS procedures leads to faster recovery and early return to work, though we still need a dedicated prospective trials in the subset. These are my references.
Thank you very much. I'll invite the judges for questions. Ashok sir, you can start.
Dr. Naveen.
Yes, sir.
No, yeah. It gives me pleasure actually to hear that even open till if I'm I'm a non-endoscopic surgeon, and that has given equally good results. This thing. In the initial, I think you quoted some 4 or 5 groups of articles, and the initial 3 almost said the 2-year follow-ups all look equal data. In fact, in both the groups, like except that back pain was return to back pain was much better in MIS as compared to, but at the leg pain, the VAS score of leg pain was possibly better with open surgery.
Yes,
Can you
sir.
elaborate on that? And was there any difference later in other studies as compared to the vascular as far as back pain is concerned and leg pain is concerned?
So the one study I showed, it was showing leg pain was less in open surgeries compared to MIS surgeries.
Okay, okay. What do you think is the reason for that?
Sir, open surgeries, we can expose the foramen and the canal more properly so that we can decompress the nerve root thoroughly compared to MIS. And in ischemic listhesis, as there is a foraminal stenosis more, so we have to decompress the opposite side foramen also, which is difficult in MIS compared to open.
Not very satisfactory. Did you look for this particular point in other articles? Any difference between the leg pain and back pain? Vasco? Because
No,
you
sir.
put it on
The one article, Ali et al., only that study showed difference in leg pain. Rest other studies are all showing equal statistically significant scores.
okay, so you presume even the leg pain has improved markedly.
Yeah, only the one study showed leg pain is better in open surgery. Rest all showed equal pains.
Okay. Rajan Agnivesh.
So, Dr. Naveen, are you talking about the contralateral leg pain or you're talking about ipsilateral leg pain?
Sir, both actually. In ischemic listhesis, as there is a bilateral defect, both legs will be painful.
No, no. The point of question what Ashok sir was asking was you said in one of the articles showed that open TLIF, the post-operative leg pain is better, right?
Yes.
Yeah. So was it specifically referring to the ipsilateral side from where you did the TLIF or it was talking about contralateral leg pain?
Actually, sir, that study was not specified to is it a ipsilateral or contralateral. They have just told that leg pain was better at open. They haven't mentioned about a specific side.
Okay. So based on your review of literature, so whatever information you have at hand, can you specify two indications when not to do open TLIF and two indications when not to do MIS TLIF?
Sir, can I get the question again? I didn't get it. Sorry.
The question is that can you specify any two indications where not to go for a open TLIF or even one indication which you have gathered from your review that, okay, this is not a case for a open TLIF or this is not the case for a MIS TLIF?
I'm not sure, sir.
Can I ask you the question in a different way?
Yes, sir.
Yes, Ashok sir, please go ahead.
Yeah. Dr. Naveen, what do you think is the cause of radiculopathy or the leg pain in listhesis patient? Possibly that might. Did you get my question?
No, sir.
And I
Sir,
said,
cause for
what is the cause of a leg pain or radiculopathy in a listhesis patient? You have three groups of symptomatology, right? You have the back pain because of instability. You have the claudication because of the caudal equina compression and the radiculopathy, leg pain,
yes, sir.
right?
In listhesis
Ah,
patient, you are asking, sir.
yeah, in listhesis, particular to your topic.
Yeah. Sir, because in listhesis, as the fragment moves forward, the foraminal, the root in the foramen will get compressed. Because of foraminal stenosis, it gets.
Okay, so
radiographic.
so which are the cases which requires a proper foraminal decompression? Is it the ischemic lytic patients or a degenerative with severe facetal degeneration?
Hypertrophic degenerative cases, sir. Hypertrophic facets, high-grade listhesis do open, and for home-based patient, we need a MIS.
Can you answer now Dr. Agnivesh's question? Okay, which are the indications for MIS and which are the indications for open?
Yep. Indication for MIS will be mostly obese patient, and for open will be dense severe stenosis, hypertrophic facet, and high-grade listhesis, which favors in open TLIF.
All right,
Okay.
thank you.
Yeah.
So Raj, any questions?
Just one simple question. Apart from VAS and ODI scores, any other scores you checked, like fusion rates, satisfaction rates of the patient, open versus MIS? Fusion is important criteria for the results. Dr. Naveen Kumar.
Yes, sir. Fusion was mentioned in many articles, but other than that, quality of life I have checked. One study showed ED 5D questionnaires. Other than that, nothing else, sir. And
Thank you. Nice presentation.
yes, sir. One
Okay.
study with Parker et al. Showed that return to work as a specific criteria. Out of 137 studies, he had showed 5 studies were showing return to work.
Thanks, Dr. Naveen. Dr. Rushikesh is not present today. Dr. Deepika, you can start sharing your presentation. So judges, please note, keep Dr. Rushikesh's mark sheet blank. Yeah, go ahead, Dr. Deepika. We can see your presentation.
Hello, am I audible?
Yeah, you're audible.
Yeah. So
But
I'm
your
Dr.
camera
Deepika.
is off.
Yes, sir. I'll just start it.
Okay, go ahead.
Yes. I'm Dr. Deepika. I'm currently a spine fellow in Mumbai, and my thank you BOS for this opportunity. So my topic for today is MIS TLIF versus open TLIF, difference that persists in 2025 synthesis. So as just 1 second, sir, I'm not able to go to the next slide. Yeah. So I'll restart. So, TLIF has been a gold standard for lumbar fusion surgeries. Open TLIF has been time tested, but it comes with its own disadvantages of soft tissue trauma. MIS TLIF uses a smaller tubular corridor, preserving the multifidus and hence redefines TLIF. So, over the past 2 decades, multiple evidences have been available and mixed reviews are available. So in the earlier studies, longer operative time and steep learning curve for MIS was known, but more recent data shows a more balanced outcome. So what are the unresolved questions? Does MIS truly reduce adjacent segment degeneration? Are cost savings and functional benefits sustained long term? And does the new technology alter the balance? So this is a narrative review done over by PubMed Index articles over the last decade to determine what differences do exist. So first, talking about the patient's outcome. Pain in retrospective analysis, pain showed significant difference in the open cases as compared to the MIS cases. MIS TLIF cases decrease. MIS TLIF cases shows decrease in the VAS and faster ODI improvement in the earlier situation, that is in the earlier 6 months. But long-term outcomes with VAS and ODI are quite similar, and the quality of life index is also equivalent. So patients do achieve. Patients walk faster, reaching the same peak sooner. So this is a study that shows that study shows that MIS TLIF lower disability in early preoperative period, and the NRS for back was achieved 25 days earlier as compared to the MIS cases. The quality outcome data-based registry over 297 patients showing 5-year long-term robust outcome showed that there was fractional better outcome in the ODI and the NRS in the MIS group as compared to the open group. So MIS recovers faster, but a 60-month NAS study shows convergence of outcomes of both VAS and ODI. So in 2025, we do more than fusion. We talk more than what fusion was achieved. So how gently it was achieved. So perioperative gains by MIS TLIF has been a clear winner. So meta-analysis with comparative outcomes among MIS and open groups over 10 articles show that the operative time shows no clinical significance, but the blood loss, post-operative in-bed time, and return to work is much higher and clinically significant in the MIS group as compared to the open group. So what about fusion? All meta-analysis, RCT, and level 1 evidence shows that equivalent fusion is achieved in MIS as well as open group, and there is no inferiority in the fusion achieved with the MIS group. To add to this, the lumbar lordosis and the segmental lordosis show no statistical difference among both the groups. So what are the long-term outcomes over 7 years? They show durable fusion outcome, slightly higher reoperation rates in the open TLIF group as compared to the MIS group. Radiologically, ASD, more than 50% higher chances in the open TLIF group. And while symptomatic ASD also slightly higher in the open TLIF group. So this can be attributed to the multifidus and the posterior tension bend, which is preserved in the open TLIF, MIS TLIF as compared to the open TLIF group. Radiographic analysis of post-operative paraspinal muscle on T1 weighted image show higher fat infiltration at operated cranial and much higher in the caudal group, both in the multifidus and the erector spinae, and hence the higher chances of degeneration. Subgroup analysis with obesity, magnifying the advantage of MIS TLIF with lesser tissue damage, lesser dead space formation, and meta-analysis across 6 studies with 654 patients shows that the wound complication is quite less in the MIS TLIF group and as well as the dural tears, and hence better outcomes. MIS TLIF has been a game changer in the elderly population, which have higher preoperative risk, but shows equal and similar improvement in pain, function, and quality of life, while the comparative rates of perioperative complication. Long-term results here show that the patients, although do have longer length of stay and more readmission, but PROs at 5 years remain constant. MIS TLIF is an economically efficient fusion, with the OR costs being high due to skilled equipment, but the total hospital cost is less due to decreased shorter stay at the hospital. So prospective QOD data shows that return to work in MIS is much higher and much earlier than the open group. Quality adjusted life years also are gained higher in the MIS group as compared to the open group. Complications have been well studied. So open MIS TLIF have slightly higher complications. The main is the wound infection, which is much higher in the open group as compared to the MIS TLIF group, as well as the blood transfusion rate, which increases the morbidity of the surgery of open TLIF as compared to MIS TLIF surgeries. The trade-off main is the radiation exposure, which is much higher in the MIS TLIF group. But with navigation and robotics, which has redefined the modern MIS TLIF, decreased risk to comparison with the open TLIF group. Learning curve shows historically learning curve shows that a surgeon takes 40 to 60 cases for the initial parity to reach open TLIF outcomes, and for the complications to stabilize. But this is being flat. This curve has been shown flattening due to learning curve in half due to navigation and robotics, and the fluoroscopy exposure is reduced by 1/3. This meta-analysis shows that the screw placement and proximal facet joint violation has been much less in the robotic era as compared to the MIS, as conventional MIS TLIF groups. And but the increased operative time is a major concern with the navigation system. So, complex spine pathology, surgeon has always chosen open TLIF as compared to MIS, as it gives better deformity correction and better outcomes and better adhesionolysis in revision surgery. But currently, MIS TLIF and hybrid approaches are catching up. MIS TLIF in high-grade spondylolisthesis, which was earlier managed with open approaches, literature shows that MIS can achieve equal reduction outcomes and equal clinical outcomes in both. So, to summarize, blood loss, hospital stay, early pain recovery, faster functional ODI outcome, decreased complication, decreased ASD, decreased infection, good cost effectiveness and return to work is there with the MIS group as compared to the open. But equal outcomes are seen in fusion rate and long-term outcomes of MIS. However, evidence gaps are present due to heterogeneous group, variable follow-up, surgeons' experience and surgeons' bias, and long-term ASD data is limited. So the future seems exciting with a radiation-free modern MIS TLIF and expanded applications of the MIS applications. And we require multi-center registries and national registries for ASD tracking. So to conclude, MIS and open TLIF both are effective tools in spine surgeons' armamentarium. MIS TLIF delivers equal fusion, equal function, but less trauma and faster recovery. It benefits more in the elderly, obese, and work age population. Complete fusion and solid decompression remains the non-negotiables in both the cases. And radiation and learning curve concerns are being neutralized by technology and training. These are my references. Thank you.
Thank you very much, Deepika. We invite the judges for questions. Ashok, sir, you can start.
Yeah, good presentation, Deepika. I think our goals were pretty well defined. What you said, including the latest in like MIS with robotics. Possibly that might be improvised. This thing. One more good thing which I found out is probably the adjacent segment disease. I don't know. I think how long is your data in MIS regarding
Sir,
adjacent
the
segment
adjacent
disease?
segment, thank you for the question, sir. The adjacent segment disease study was a 7-year study where it showed more radiographic and more symptomatic ASD in the open group as compared to the MIS group. But we need longer studies to determine.
Okay, the 7 years is a bit too short a period. Fine. Okay. Okay. Yeah. Good presentation. Ramesh, yeah.
Yeah, good presentation. No question, Deepika, sorry.
Thank you, sir.
Raj,
So
you
I
have
have
some
one
questions?
question. Yeah. So Deepika, you just finished the fellowship and you are your own practicing, and the patient comes to you and he asks you, like, you are still learning phase for the MIS, still 40 to 60 cases to go, and he asks you what a surgeon should do. Shall we do MIS or open, depending on the learning curve and all the results, short term, long term? What do you suggest to the patient?
So for the patient, definitely the surgeon should be experienced enough that he has crossed his learning curve to do an MIS TLIF. But I would also want to cross my learning curve. So with under the guidance of experienced surgeon, I would definitely advise MIS TLIF, as I know that the outcomes are definitely much better in the earlier period. So why should the patient wait for 2 years to achieve outcomes same as open TLIF?
Deepika, can you like identify the indications for an open TLIF and MIS TLIF?
So currently, all virgin cases can be managed, according to me, by MIS TLIF. Even high-grade spondylolisthesis, if the patient chosen properly, and if you're getting good some little amount of reduction on table, then I think MIS TLIF is a go. But in cases of infection where thorough debridement is required, tumor, where fusion has to be done, and cases of complex ASD where more than three, or a patient requires a more than 3 level of MIS TLIF, where the MIS TLIF loses its outcomes, early outcomes. I think in those cases, open TLIF is required, as well as degen scoliosis. So.
Okay, I think you can go ahead.
Okay. Thank you, Deepika.
Thank you, sir.
I'll invite Dr. Nrupam for a presentation. You can share your presentation and we can start.
So is my presentation visible?
Yeah, we can see your presentation. Go to slideshow.
So I'll just start. Am I audible?
Yeah, you're audible. Your video is not seen. You can start the video too.
Sorry, so I'm not able to.
No, you can see the slideshow. You can
So I'm
start the
actually
slide.
able to start my video.
Are you on a tab
No, sir. Yes,
on a
sir.
laptop? Okay.
Good evening, sirs. So I'm Dr. Nrupam Mehta. I'm a spine fellow working under Dr. Abhay Nene right now. Thank you for this opportunity to let me present my review today. So my topic for today is static or expandable TLIF cages. What is my comparison in 2025? So I will highlight why do we need cages first of all. Is it for fusion? Do we get immediate stability out of it? That's why. Is it for sagittal balance correction? Is it for coronal balance correction? As you can see from the X-ray at the bottom, the L4, L5 disc space is completely reduced. There's foraminal stenosis. There is no disc height. So the cages are mainly indicative of increasing your disc height, release the foraminal stenosis with the help of indirect decompression, and also to restore an adequate lordosis for the biomechanics of the spine. So basically, as we all have already gone through all the previous presentations, highlighting what is TLIF, I'm not going to go into that. Basically, when we come down to the cages that are used in TLIF, the transforaminal lumbar antibodies that we are using, from the late 1900s to the early 2000s, this was introduced. Basically, a static TLIF cage is a solid pre-shaped implant that is inserted between two lumbar vertebral bodies after disc removal to restore the disc height, to provide anterior column support, and to promote bony fusion between the vertebrae. So as you can see, these pictures are of the two most commonly used TLIF cages, the banana type and the bullet type. Why are these cages called static? Because they don't change in size or shape after insertion. It remains exactly as manufactured after insertion. The sizes typically vary from 6 to 14 millimeters in height, and they usually have a fixed lordosis that ranges between 4 to 12 degrees. So why did we have to come down to expandable cages? Basically, inserting a fixed size cage through a narrow corridor was very difficult. We were not getting adequate lordosis. Because of that, we were putting undersized cages, or we were in sheer fear of damaging structures around. There was significant nerve root retraction that was needed. There was end place damage from forceful impaction. And as the in the recent few years, everyone has been talking about the spinopelvic parameters. As I've highlighted in this X-ray, the lumbar lordosis, the segmental lordosis, the sagittal vertical axis, the sacral stroke, and the pelvic incidence. It has been consistently seen, and it's an evolution. It's going through evolution that if you restore these parameters, the patient is usually happier. The rate or the time to which they come back is more, and in general, it's important to restore these parameters and the biomechanics of the spine when we are operating. So what is the aim of my review today? To assess the pros and cons of using static and expandable TLIF cages. Is one cage superior over the other? And the way I've reviewed the literature, I've gone through the electronic databases and have only filtered the last 5 years. There's a reference list of the selected articles and index articles that I've used. I have gone over all the meta-analysis mainly that were done over these past couple of years. And finally, I chose articles from journals with higher citation indexes for my final review. So I have specifically highlighted articles that have themselves gone over 15 to at least 20 articles and made their meta-analysis. So while I was reviewing, I was considering these key points that I would assess if static or expandable is better, or what the review articles were saying. So what were the complications after the surgery, irrespective of static or expandable? What was the patient outcome? Was the patient happy? Radiologically, was there a vast difference? Was there an insignificant difference? And what was the failure rate? What was the fusion rate, if that really mattered? And what was the subsidence rate? So we'll start with, this was an article that I found by Dr. Mohammed Dhar that was published at the early Feb of this year. Basically, he has analyzed 15 retrospective articles and gone over 2447 patients, which 1400 majorly were using static and the rest were done using expandable. Basically, he highlighted that patients, while inserting the expandables, had lesser chances of root injury, dural tear, and retraction injuries, because you could insert smaller cage-sized cages inside the disc space, and then you could expand it. So the retraction was less. Post-op radiculitis, which you would expect in static to be higher because of the local trauma, was not significantly higher in the static group. The next one is, this is again a retrospective study, a meta-analysis done from 13 different articles, which was analyzing almost 417 patients. They have very systematically showed us about patient-related outcome measures using the ODI score and the VAS scoring system. As you can see, the charts that are shown here, it basically shows that patients with static cages had persistent back pain and leg pain, maybe because of not inadequate segmental lumbar lordosis, inadequate lumbar lordosis restoration. So they basically highlighted that it is important for good patient-related outcome measures that there's adequate segmental lordosis, there is gaining optimal sagittal balance, and that causes reduced back pain and increased functional outcomes for patients. The next big article that I found was basically highlighting the subsidence rate that expandable cages were showing, which was as high as 16.6% in expandable as compared to 9.2% in static. They have also highlighted a case that they had shown in this paper. Basically, at 1 month after the TLIF, this was the X-ray A, and 12 months after TLIF with expandable, you could see a considerable collapse and loss of height of the cage. 40 months after this, you could see there is a screw breakage and there is pseudoarthrosis. And the last X-ray highlights how they had to go in again. So in this paper, they mainly emphasized on the subsidence that is very unpredictable in expandable cages. The next journal that the next article that I found was published by our spine stalwarts, Alexander Crawford, Simpson, Schoenfield, everybody. Basically, they analyzed almost 417 cases retrospectively that they had collected from 31 surgeons who had a mean age of 62 years of age. They basically said that they did consecutive post-op X-rays, and they analyzed the lateral views at day zero, at 6 months, and at 1 year. So initially, the radiological parameters that were restored and showed excellent radiographs at 0 and 6 months was actually not the case at 1 year. There was no significant difference between static and expandable cages at the end of 1 year. And that's what they basically highlighted, that just getting a good radiological outcome doesn't necessarily mean that at 1 year also you would receive the same outcome, and at 1 year it's going to be clinically relevant to the patient. The patient may still come back with all possible complaints that they had earlier only because of the subsidence. So the next thing was, what about minimally invasive surgery? Is going static better? Is expandable better? So this basically it was just a 1 year clinical and radiological outcome in minimally invasive TLIF. So it mainly highlighted that expandable cages did have a higher subsidence rate, but it was not significant enough. So actually they were highlighting that maybe just because of the ease of putting expandable cages through the narrow corridor in MIS, you could still do it. The subsidence rate, they didn't find significant. So that is not a good enough reason for us to disregard it and to not go for expandable cages. As you can see that in their statistics, subsidence at 1 year follow-up on static had 19.7% and expandable had 22.4%. Also, the next one, which was published in the Journal of Spine Surgery, it basically made us think, or in amongst the reviews, that is the design actually mattering? We may say, first of all, it's between static and expandable, but even in expandable, would the design matter in a way of just increasing the height or also increasing the lordosis? So basically, this was a clinical study that was conducted over 3 years, where two groups were formed. One where only height cages were given, and the other where height and the lordosis could be extended and increased. So they significantly found that in the height and lordosis group, that is the HL group, they did much better even in patient-related outcome measures as well as radiologically. And therefore, they have said that the design does matter. Also, the other thing is, since static is easier to deal with because it's known to surgeons, it's been going on for the last 2 to 3 decades. It's easier for the surgeons, the learning curve is not as much. And expandable cannot be reduced in height again. So once we have overexpanded cage inside the disc space, it's not possible to come down, which has its own setbacks. In fact, I've not added it to this presentation, but there was a case report that I read which basically spoke about overexpansion of the expandable cage, which in an already weak anterior longitudinal ligament that caused a strain and tear of the ALL. And then there was anterior migration of the cage because of that. So that is something that we should definitely consider and look into. This case or this study also highlighted that the author, because it was conducted at a single center, he also highlighted that after 20 to 30 cases of using the expandable cage, he was able to get the lordosis right. He was able to not overexpand, and he was able to.
Dr. Mehta, can I stop you there?
Yes, sir.
It was 7-minute presentation, right?
Yes, sir.
You
Yes,
are
sir.
already on your 11 minutes.
Yes, sorry, sir.
Yeah, please conclude.
So my conclusion is that with no significant differences clinically and radiologically in long-term follow-ups, largely static would be better due to the high subsidence rate of expandables and predictability of using the static ones. Logistically and economically superior was the static cage as well, and specifically use expandable only when the case demands it. Because being in the uncertainty of whether it's going to go and lose disc height over a span of 1 to 2 years is not worth it. So these are
Thanks
my.
a lot. Open to judges for questions. Ashok sir.
Yeah, Rupam. Okay, overall good presentation, but yeah, definitely overshoot it a bit longer. My question is whether, hello?
Yes.
Go ahead, sir.
Yeah.
You are.
One article which you reviewed and said with expandable, are there definitely a subsidence?
Yes, sir.
Yeah. did you go into details about whether it is the expansion of the cage which gets reduced and back to the original size, or is it the subsidence into the bone?
So it was the subsidence into the bone, sir. That's what they were highlighting. That it does even lose height in general, but it also causes subsidence. So they were checking with the anterior disc height and the posterior disc height, and they have measured the differences and checked that, sir.
Yeah, because subsidence into the bone, then it depends on your disc space preparation and the loss of subchondral bone.
Yes, sir.
And like as you mentioned earlier, the expandable ones has got lower rate of end plate fractures, or like, because then you tend to hammer it basically much less as compared to, I mean, you only tack it inside.
Yes, sir.
In the expand.
Yes,
So
sir.
like, what could be the cause of increased subsidence in an expandable cage then? Since we are not hammering the cage, we are not doing much.
So actually, depends on the case we have chosen. If the patient is
Or is it, or is it that we miscalculate the size of the cage, expandable cage?
So the first new surgeons initially, yes, from the study that I presented last, it is a miscalculation of the expansion. We tend to be over ambitious and we increase the height. And because of the small surface area and the expansion forces, there seems to be a higher rate of subsidence because of that as well. And also the clinical profile of the patient. If the patient is severely osteoporotic, even then there's a study that I had gone through which says that there is increased rate of subsidence.
Okay. Any increase in symptomatology after the subsidence?
Yes, sir. So not significantly, but yes, sir. Some patients still complain of back pain, some instability pain. One of the papers actually did specify that 3% of the patients out of the patients who were underwent subsidence did have clinical back pain of instability, sir.
Okay, may I ask you one last question from my side?
Yes.
What are the things you do to restore lordosis?
So to restore the lordosis, so basically depends. One would be the rods. You can give a posterior lordosis. You can give a lordosis to the rods that you give. Second, in the T-lift cages, in a static cage, they come with a fixed lordosis. So that also anteriorly opens up and posteriorly jacks up the disc spacer. That is another way of giving the lordosis. And so these would be my two primary that I would think about. And in expansion, again, they anteriorly it expands more compared to the posterior. So in expandable cages, also that would cause an increase in the lordosis.
Once you put in the cages, then you tend to compress. I mean,
compress the posterior part and.
Yeah, you're supposed to compress it, the posterior part, to restore the lordosis. So it is not only the cage; it's overall like a few steps which you do to restore the lordosis.
Yes.
There. Okay, Abhish.
Dr. Raj, you can go ahead while Agni finishes.
Yeah. So nice presentation. So my question, as the world is moving more and more towards the MIS with the more tiny incisions, and it's been proven that there is less chance of nerve injury, dural injury with the insertion of expandable cage, and it has the similar results. What's your thought of not using expandable? In which cases you want to use the expandable?
So basically specific to MIS, I would, from the review that I've done, I feel it is okay to use expandable. Where I wouldn't use expandable would be in severe infections. That's something I would not, because the end plates are anyway not the best. Second, end plate preparation will not be done well. Third, I would not use expandable in maybe, and in infection, I also need more mechanical stability. I would not use expandable in severely osteoporotic as well, because again, that would cause subsidence and plate fracture and all that. And I would rather go with the old conventional static cages in that case.
Any comparison have you done with respect to uh, types of like static cages, like the banana cages and
Yes, I'm
your
not.
typical?
Yes, so I have read through it because so basic difference between the bullet and the banana cage would be the banana cage actually occupies more footplate or footprint in the vertebra, which is better for fusion. It's better even for the lordosis because banana cage also has a differential width anteriorly and posteriorly. So that also helps to distribute the forces across, and it doesn't have a narrow expandable or expansile force across the vertebra, which leads to subsidence. So in general, when I have gone through some of the papers, the banana is definitely better than the bullet or the original P-lift cage. So.
Okay.
Okay, any other questions, Agnivesh? Okay. Thanks, Dr. Mehta. I'll invite Dr. Vasu for sharing his presentation and we can start with it.
Yes, sir.
Go ahead.
So is my screen visible?
Now it is visible. Make it
Am
full
I audible,
screen.
sir? Yeah.
Yeah, you're audible.
So, second.
Are you sharing like a video?
No,
Because I
sir.
can see the Zoom panels on the slide. Make it full screen.
Yeah.
Slideshow.
Have you installed the Zoom app or are you using the web version of Zoom?
So the web version of Zoom.
That is why this is happening. Just minimize everything.
Yeah, drag it out of the visible area. Take it down the upper part also.
You should always install the Zoom app. Why have you not installed the Zoom app?
But it's on the Zoom app only, sir.
You are on the Zoom app or you are on the Chrome browser of Zoom? That is what I'm asking.
The Zoom app.
So then this should not happen. Just
Then
stop the screen share
Yeah, stop and reshare again. That's it.
and reshare only the PowerPoint. Do not reshare, do not share the whole screen.
Do not share the desktop. Share only the PowerPoint.
No, the same problem is happening.
Maybe an update is required.
Just minimize the right side videos where you are seeing everybody's videos. Just minimize that and don't bring it down. You brought it down, just minimize it. Yes. And this band you see where there is join, record, mute, everything, that just try to bring it. Yeah. Now you can start.
okay. Good evening, sir. I am Dr. Vasu Jindal. I am currently a FNB Spine Fellow at Amandeep Hospital, Amritsar. So, topic given to me today is current management algorithm of lumbar spine tuberculosis, how to treat medically, when to operate, and how to monitor response. So, according to the Global Tuberculosis Report 2024, tuberculosis is a notifiable disease. TB is among the top 10 causes of death worldwide. Most of the people who develop TB disease each year are in 30 high burden countries, among which India accounts for 26%. There was a multi-center study on bone tuberculosis conducted in China as well as in India, in South India, which shows of all the TB patients, extrapulmonary TB accounts for 24%, of which skeletal TB, being the fourth most common form, accounts for, and the spinal TB accounts for 50% of all the skeletal tuberculosis. And we see thoracic tuberculosis account for 34%, and the lumbar tuberculosis account for 32% of spinal tuberculosis. So before we start our presentation, we should know what are the lab investigations we should do and we shouldn't. So what to do is hemoglobin, total leukocyte count, differential count, erythrocyte sedimentation rate, RBS, HIV, and what not to do is PCR test, antibody test,
gold test, and the Montu test. So radiological investigations are also must. The first investigation is an X-ray, but MRI is the gold standard radiological investigation, which helps in early diagnosis of tuberculosis. How MRI is good among the other investigations, as MRI gives us well-defined paraspinal abnormal signals on MRI. MRI shows thin and smooth abscess walls in abscess. It shows subligamentous spread. There are multiple vertebrae involvement as well as thoracic and lumbar spine involvement. We should also know that tuberculosis is a great mimicker. It can mimic pyogenic infections, eosinophilic granuloma, lymphomas, and metastasis. So what to do? Biopsy is a must and always sent for gene expert, culture, and histopath. And endemic areas also sent for fungal culture. So now the topic, when to treat medically, when to operate, and how to monitor. So there was a study uh, published in Asian Spine Journal, which comprehensive spinal tuberculosis scope, which includes various parameters like pain, kyphosis angle, destruction of vertebrae, neurological status. And among that, score which was less than 5.5 was treated conservative. Scores between 5.5 and 6.5 were treated ambiguously, and scores more than 6.5 were treated operatively. So, what are the surgical indications? Surgical indications, neurological deficit, which includes severe neurological deficit at presentation, new onset or deteriorating or unimproved deficits after chemotherapy, severe vertebral infections, which involves panvertebral disease, spinate wrist signs, lack of improvement in pain after 6 weeks of chemotherapy, spine instability pain, kyphotic deformity, which is more than 30 degrees in earlier tuberculosis, and late tuberculosis with neurological deficits. Also, the instability. So there was also a scoring system developed, development of tuberculosis spine instability score, which involved various parameters like age, location, pain, adjusted kyphotic deformity, which includes an additional 5 degrees of kyphosis for lumbar as well as cervical spine, vertebral body loss, additional involvement of posterior spinal segments, multifocal contagious diseases, intervertebral or the paravertebral abscesses. So the score less than 7 was considered stable, 7 to 10 was considered as impending stability, and more than 10 was considered as unstable. So an uncomplicated case is a medical disease. So a study documented by American Thoracic Society documents has revised a tuberculosis guideline in 2025, which has major change, which includes ethambutol is out and moxifloxacin has come in. And overall, the treatment regime, which was from 6 months, has been reduced to 4 months. So what are the differences of rifampicin versus rifapentin and moxifloxacin versus ethambutol? So ethambutol is more potent in culture positive tuberculosis. It has lesser side effects, such as ethambutol has more ocular toxicity, which is less in moxifloxacin. And rifampicin and rifapentin has more half-life as compared to rifampicin. So it is excluded out of the blood more delayed as compared to rifampicin. It has more protein binding affinity. It has lesser side effects, and it induces more cytochrome 450 enzymes, which helps in killing of tuberculosis bacteria. So how to monitor response? Earlier, we used to monitor response clinically, laboratorically, and radiologically. Recently, a new parameter has been added, which includes PET-CT. How PET-CT is important in other parameters, as it includes detecting of latent as well as active tubercular bacteria into the spine, which can be monitored after every 6 months, 12 months, and it gives us a prior information that patient is going to worsen or patient is going to improve in, depending upon the latent phase and the active phase of the tuberculosis. So what is called as a treatment failure in medically treated cases? A strong clinical suspicion of a treatment failure, other evidence of active tuberculosis, not confirmed on a biopsy or not confirmed on a culture, that is drug resistance. How do you confirm bacteriologically confirmed treatment failure? Patient with treatment failure, microbiological evidence of persistent M tuberculosis infection on repeat diagnostic sampling. Questions to ask children and adolescents who are not responding to tuberculosis and are on TB treatment. Are they really taking correct doses? Is a child taking the medicine as prescribed? Is it possible that the child or adolescent has poor gastrointestinal absorption? Does the child have any medical toxicity? Does he have any HIV or any opportunistic infections? Is the child severely malnourished? Is there any suspicion of drug-resistant tuberculosis? Or is there any other infection in addition to tuberculosis? So, a surgical treatment of spinal tuberculosis. What are really goals of surgical treatment? The real goals are decompression, deformity correction, and stabilize the spine. So, how do you do all of this? We can do either anteriorly, posteriorly, or we can combine both anterior as well as posterior approaches. So, anterior approaches, what are the advantages? It gives you a radical debridement. It reduces the risk of dural injury. Structural anterior support. What are disadvantages? It is riskier to abdominal organs as well as vessel. When you do unilateral fixation, it leads to biomechanical instability and it is difficult to instrument more than 3 segments. So what is real indication is less than 3 motion segments. Anterior psoas abscess, when the height is more than 1/3 of the normal vertebrae, when the kyphosis angle is less than 40 degrees. For the posterior approaches, advantages are it reduces the chances of abdominal injuries. You can harvest the bone graft, which you can put in the interior. You can do deformity corrections. What are disadvantages? It really contaminates your posterior field through your anterior column. Very small surgical window. It is non-conducive for structural bone graft to anterior column, and usually a long segment fixation is required. Indications are TB lesions located in the posterior segment, segments less than 3 involved, iliac vessel bifurcation, and multiple anterior surgeries has been done already. Combined posterior and anterior approach, advantages are sufficient decompression of spinal cord and nerves, deformity correction, and internal fixation via posterior approach, radical debridement, structural bone, and graft placement. Disadvantages are it provides larger trauma to the patient, longer operation time, more bone loss, complicated surgeries, and high risk of abdominal vessels. Real indications are more than 3 segments involved, lumbosacral junctional area, severe vertebral destruction, spinal cord compression, and the kyphotic deformity. So I would like to conclude all uncomplicated spinal tuberculosis treat medically. Biopsy is mandatory to confirm the diagnosis, ensure compliance, adequate drug dose by continuous monitoring. Surgery is indicated in patients with neurological deficits and instability. If surgery at all is indicated, posterior only surgery is adequate in most cases. Thank you.
Dr. Vasu, you can stop the screen share. The judges can now ask the questions.
A good presentation, Vasu. You did not specify what is uncomplicated TB.
All the cases which are not complicated are uncomplicated. So the complicated cases include, so there's a scoring system, a comprehensive tuberculosis scoring system, which has various parameters. And according to that scoring system, a score more than 6.5 is all considered as complicated cases. And any score less than 6.5 would be considered as uncomplicated cases, sir.
What's the topic of this presentation?
So my topic is when to treat medically, when to operate, and how to monitor.
Okay, try to cover up in 7 minutes. It'll be difficult anyway. Yeah, Rajan, Abhinesh, yeah, go ahead.
Yeah, Dr. Vasu. So, if you have to summarize your literature review in 3 lines as when to conserve, when to operate, and when to go anterior. So, can you summarize it in 3 lines?
So when to operate is when a patient is developing a neurological deficit or any instability, or if the patient symptoms are not improving despite any conservative treatments. So for medical treatment, any patient which do not have any neurological deficits, showing good response with tubercular regime and no cause of instability with improving symptoms. And for the patients, when to operate anteriorly, sir, when a patient has less than 3 segments involved, entirely destructed vertebral bodies anteriorly, patient has an anterior psoas abscess and like very great abscess which cannot be debrided thoroughly through a posterior approach. So then it is recommended to go anteriorly debridement and fixed fusion surgeries.
So, Dr. Vasu, is it really necessary to run after abscesses and debride them wherever they are? Or is it okay if we just leave them for the medicines to be taken care of?
So abscesses do not really, if the patient is already not improving on medicines, we need to reduce the tuberculous load from the area, and it's better, and patient has an instability. So we really need to instrument and debride anteriorly, sir.
What about children? You did not mention about the age group.
Sir, in my presentation, there were a new tubercular regime has come, which has include children, and there's a different dosing system according to the children, sir. Well, medicines are same, just the doses are different, sir.
No, the indications for surgery.
So indication for surgery in children are almost the same, as well as the spinate wrist signs, which involves facetal dislocation, spine toppling, retropulsion of segments.
Now, how can that be the same indications in children in a growing spine as in an adult static spine? Can you just clarify your sentence or your statement that both indications are same in both growing spine as well as in the adult static spine?
So, no, sir.
Okay. Raj?
Yeah, so nice presentation also. My question is, could you slightly elaborate with the patient with multiple levels of tuberculosis involvement, but there is no mechanical instability or neurological deficit? What medical management you will suggest in this patient and duration?
So if a patient has multiple spinal involvement with no neurology and no instability, so I would like to go ahead with a medically treatment. And with the recent upcoming guidelines, I will give a treatment of 4 months, which include HR, Z, and M, moxifloxacin, and instead of rifampicin, it is rifapentin. For the first 2 months, HRZM, HPZM, and for the next 2 months, HPM. We'll exclude the pyrazinamide and we'll give the 3 drugs for 2 months.
Is this the difference from RNTCP program or you quoted American?
So this is the recent guideline published in 2025 for the tuberculosis treatment, sir.
Published by?
American Journal of
The
Thoracic
American
Spine, sir.
thoracic this is the American thoracic guidelines, and the bacteria and the virulence is totally different in the Indian and subcontinent, and it's
Why you
totally
did not
different in
refer to the
American
Indian literature?
RNTPC and DOTS literature. I think you should have mentioned rather than the American.
Like anything preventing you from like accessing the data of the Indian National Tuberculosis Program?
So in India, this tubercular regime has not been started yet, and there were no data which provide information regarding that this treatment is better or not better has been included. So, there was this treatment was only published through American journal and not provided by any Indian journal, sir. But this is the recent guideline, so I tried to mention this in my presentation, sir.
Actually, but you could talk to any of your chest physicians regarding any latest developments in RNTCP or the National Tuberculosis Program and what are the outcomes. I think.
Okay, now we invite. Last questions are over. Raj.
Yeah, I think. Thank you.
Yeah.
Okay, so we invite Dr. Abhijeet to please put on his video and start the presentation. Share screen. Abhijeet, are you here?
Yes, sir. Yes.
So go in full screen mode, slideshow
Yes.
mode. Okay, we can see
Shall
it
I
now.
start,
You can
sir?
start.
Good evening, everyone. This is Dr. Abhijeet. My topic for today's discussion is degenerative spondylolisthesis, decompression alone versus fusion, latest RCT bar pole data. These are the contents of my presentation. Starting with the introduction, as we all know, degenerative spondylolisthesis is a widespread pathology with prevalence of more than 25 to 43% in women and 19 to 31% in men over 65 years of age. When such huge is the burden, there has to be a tailor-made solution for it. But does that exist? That's a question mark. Whenever we get such patients in clinic, there's always a dilemma whether to fuse it or to decompress it. This dilemma is because of our past and recent past studies. So starting with the most past one, that is from 1970s, where both of these landmark papers told that fusion after laminectomy were considered unnecessary. But in 1991, Harkowitz explained in his paper that fusion is one amongst the good alternative for the degenerative lumbar spondylolisthesis treated with instrumentation. Followed by 1997, where Fishgren also told that fusion is better when compared to decompression alone. Then came the landmark paper by Kornblum, which was published in 2004, after which there was a rampant shift in the treatment protocol, shifting it towards fusion rather than decompression alone. So here we have certain studies favoring the decompression alone in case of degenerative spondylolisthesis. And the most recent and the most superior study was the Nordston DS study, that is Norwegian trial with level 1 evidence. And here they have assessed regarding whether decompression alone is non-superior to the fusion for degenerative lumbar spondylolisthesis. This study is superior because it is an open-label, multi-center study comparing non-inferiority of decompression alone in comparison to fusion, where degenerative listhesis with stenosis patients were taken, and there was no proper clear-cut demarcation about the listhesis. All patients of listhesis, irrespective of the degree, were included, and the data which they acquired was of 5 years follow-up, included 16 orthopedic and neurosurgery clinics. Primary outcome measure was ODI score, which was found to be satisfied if there is 30% reduction in ODI from the baseline to 5 years. Reoperation rates in this study, 22% was in decompression group and 21% in decompression plus fusion group. Apart from this study highlighted that there is higher incidence of dural tears and high blood loss in case of fusion, while decompression it is much lower. So as a whole, they told that decompression alone is non-inferior to fusion when we are dealing with degenerative spondylolisthesis. Another article which I'd like to quote was by Entrepreneur, which is the observational study, but it has a very unique point that the primary outcome here was health-related quality of life. This was an observational study where the primary outcome measure was health-related quality of life. The patients were 50 years and more. Here, the secondary outcome scores were change in spine stenosis measurements, physical therapy, oral analgesic use. And the conclusion, what they drew from this study was no superior results with addition of fusion in case of degenerative spondylolisthesis, as well as in patients with decompression with fusion, the physical therapy was more for about 3 years when compared to decompression group, while the leg pain, back pain, oral analgesics use, everything was similar to that of the decompression group. Another study where the analysis of randomized trials was done, and a 2-year follow-up, the addition of fusion made a very trivial difference in the ODI, which was statistically not significant. And here they also mentioned that there was improvement in the back pain, which is a unique feature without fusion, while there is a trivial difference in leg pain, which was better in group without fusion than with the fusion. And they concluded that there are no added benefits for instrumented fusion in patients with degenerative listhesis where decompression can be tried easily. While there are other studies which favored decompression fusion, the most famous study is the SLIP registry or the SLIP clinical trial, which was which is, I think, the most recent one, which was done in 2016. After that, there are no RCT trials with longer follow-up telling about the treatment protocol. In this SLIP registry, the the randomized control trial and level 1 evidence was there. The strength of this study was it is randomized prospective design, clear inclusion criteria was there, standard surgical techniques, blinded outcome, and follow-up of 4 years was taken. While the limitation was the sample size, there were only 66 patients included in the study with few and there was potential surgeon selection bias because there was statistically there were reduction variables were included in the study, and the patients were selected based upon that. And the result, what we got out of this SLIP clinical trial was that fusion was slightly better when compared to that of decompression alone, and the reoperation rate was around 14% in patients undergoing fusion, while 34% in patients undergoing decompression. So that the conclusion what they drew was fusion is better in patient with degenerative listhesis when compared with only decompression. This is another study which is a retrospective national database analysis with a sample size of more than 250 people included in the study. And here the graph shows that in late in the initial decade of the 2000s, that is from 2010, the decompression and fusion procedures were at the lower rate, but by the end of 2021, the rate of fusion was increased. And from the database of their from the database analysis, what they found was that there is increasing trend towards the fusion, and there is a surgical bias also where the surgeon is more inclined towards the fusion. So decompression with fusion has become the most common treatment despite lack of compelling evidence, was their conclusion. Another study also compared MIS TLIF with MIS decompression alone for degenerative lumbar spondylolisthesis, and the conclusion what they drew was fusion MIS TLIF is of more importance and more favorable when compared to MIS decompression for single level degenerative spondylolisthesis, and the reoperation rates also were higher in decompression group when compared with that of MIS TLIF group. So they concluded that MIS TLIF is superior to decompression alone for degen listhesis. Now coming to the reoperation rate, these are few studies which shows that the reoperation rate in decompression group was around 11% for the systemic review and meta-analysis done by Chen et al. The fusion, it was 10%, and for the decompression plus fusion, it was around 9%. Similarly, systematic review by Satish Muttu et al. It shows that overall reoperation rate was around 9.1%. In open decompression, it was 10.9%, and in microscopic decompression, it was 6.7%. Similarly, in the other studies also, the reoperation rate in decompression group was somewhere between 11 to 18%. So apart from there are literature which suggests that fusion is better, and there are literature which suggests that decompression is better. There are certain classification systems which can be incorporated into the clinical practice to decide whether fusion or to undergo only decompression. Some of these studies are clinical and radiological degenerative spondylolisthesis classification, DISC classification, Kulkarni's scoring system, French Society for Spine Surgery classification system. Out of all these system, Kulkarni's scoring system, which was published in 2020, it includes all the aspects of all the aspects which needs to be considered before the patient undergoes surgery, such as the sagittal alignment, the facet orientation, the effusion of the facets, segmental kyphosis, and the recent article in the European Spine Journal does state that all these parameters has to be
Dr.
met.
Abhijit, we will have to stop your presentation now, or you just take it to the conclusion slide.
Yes,
You already
yes,
crossed
yes.
4 minutes extra. Please
The
finish up the conclusion.
Yes, sir. The conclusion of the review includes that always assess the patient individually, use classification system and score to support your intervention, give option of decompression alone before the fusion, and explain about the subsequent classification complications. Thank you. These are my references.
Okay, you can stop your screen share and put on your video.
Sure. Sir.
Yeah, Agnivesh. Raj, you can start.
Yeah, I'm here, sir. Raj can start. Yeah.
Dr. Abhijeet, nice presentation.
Thank you, sir.
So, in what setting, your personal, there are different criteria every year, new classification comes, already 6, 7 classifications are there. So, if the patient comes to you in the clinic, what criteria you will use to define this patient will need fixation in your setting?
So the first and foremost thing which I say is the instability, sir, on flexion and extension X-rays. X-ray wise, if we are speaking on MRI, I do see about the disc degeneration, facet effusion, and the amount of listhesis when the patient is in supine. That is the dynamic state of the listhesis. That is what I usually see. And symptomatically wise, I see what the patient is presenting with, whether it is a back pain which is predominant or it is a leg pain which is predominant. But almost always, I do give them the option of decompression because the studies do suggest that there is a improvement in the back pain also. So I always give them this option of decompression alone, and there is a 10% chances of future fusion may be needed in those patients. It is as similar to that of a regular discectomy patient, where we do tell that after discectomy there is a 10% chance in first 1 year that they are going to have another operation. Maybe they can have another operation. So I always give them the option of decompression first and then followed with the fusion.
Dr. Abhijit, initially, your initial literature review all showed a long-term results showing a decompression giving better results than decompression with fusion.
Yes.
Since when the data has started changing in favor of fusion?
So, since 2004, the data has started. I mean, there was a favoring towards the fusion process. After the paper by Conman, sir, after that, the trend started shifting towards the fusion.
Because I think the long-term results of only discectomy still is quite prevalent, and with endoscopic discectomy, especially for the first time disc collapses, the first episode, people are still not opting for fusion till now. So, what's your take on that?
As far as degenerative condition is concerned, uh, I would always tell them the decompression, sir, and maybe the multiple times also because the endoscopic discectomy comes with all the advantages as well, sir. Minimal size, minimal tissue disruption, and lesser length of stay in the hospital. With all those advantages, maybe patient are more comfortable with the endoscopic discectomy rather undergoing the fusion. So,
Okay, so can you conclude your indications for fusion? My last
so
question.
degenerative listhesis with predominant back pain, instability on flexion extension X-rays, significant disc degeneration on MRI, facet effusion. If all these sums up, then I would prefer to go with the fusion.
Okay. Agnivesh?
Yeah. I think we are good, sir. All
Yeah, I
relevant
think we can
questions.
conclude. Neeraj, Ashok.
Okay. Okay. Thank you very much, everyone. And with this, we stop the today's session. And I would request judges to send me the mark sheet as soon as possible. We will have the next session next week of the trauma. Thank you, everyone. Good night.
Okay. Good night.
Thank you. Good night.
Good night. Good night. Yeah.